So let's start a little bit with the pathophysiology. There's something called Virchow's triad of thrombosis. So this is actually super interesting, and it comes up, many of you know who have listened to me before, I work in orthopedic surgery, where a major component of our drug therapy is using anticoagulants for DVT and PE prophylaxis. Now, the reason that patients are at an increased risk of developing these blood clots can be for a variety of reasons, but Virchow's triad has three main reasons that are super important to understand, putting these patients at an increased risk of potentially clotting. So hemodynamic changes, all that means is there's some sort of alteration in the blood flow. So blood is either, not moving that quickly, not moving properly, or it's turbulent. So a hypercoagulable state, that would be some sort of change in a clotting factor. So these can actually be genetic. There are patients who we see who are factor V Leiden, patients who have protein CNS deficiencies. These are genetic mutations that put patients at an increased risk of developing a deep vein clot. There's also vascular injury, so any sort of damage to the blood vessel, anything that activates the coagulation cascade, right? So if you get a nick in a blood vessel, obviously the body wants to work to fix that, so it induces a clotting state. So it's interesting because in an orthopedic surgery world, or in a surgical world in general, I usually tell my patients, because we want to explain exactly why we're putting them on some sort of prophylactic dosing of an anticoagulant. I say, you've got two of the three risk factors here. You're going to be in a hypercoagulable state because of your immobility post-op, and we've also injured the vasculature somewhat because we've done a surgery. So this is just an interesting, if you hear of a case, or you see a case on the exam and they talk a lot about two of three of these situations for a patient, you should think right away that will put my patient at an increased risk of clotting. So the pathophysiology, again, it's really important to know that clot formation, oops, sorry about that. So clotting itself is something super important. You don't want that to go away. So we're not saying that we want to be in a state of bleeding, but we just want to make sure there's no sort of inappropriate clot formation or a disruption of the appropriate coagulation system that exists in all of our bodies. So when we talk about clots, we're just talking about inappropriate clot formation. Keep in mind that you still want to be able to clot if, for some reason you've injured yourself, you've fallen, you've cut yourself. You want to make sure that you don't bleed out. So we still want some sort of coagulation cascade, just not an inappropriate one. So there are various types of blood clots, and this is also extremely important to understand the difference. DVTs and PEs fall under the umbrella term of a VTE, okay? So a VTE, all that means is a clot in a vein. If the clot in the vein is in a deep vein, that's a deep vein thrombosis, and that usually occurs in the proximal or distal. Often it's in the calf, okay? So it's in the calf most often, and that is a distal DVT. This can break off, and it can actually turn into a pulmonary embolism, in the sense that it will break apart and travel from the leg to the lung. And all of that together, again, that is the umbrella term, okay? So the difference between a DVT and a PE, again, is the location, and they all fall under VTE. So a thrombus can actually be asymptomatic. It can move, it can embolize, like I said, it can break off in the leg and then travel all the way up to the lung. The point that must be driven home here, that I say every single day in practice, is it is so much easier to prevent a blood clot than to treat one. So we need to make sure that we are counseling our patients and explaining to them that there is a severe risk of clotting post-op, traveling for long periods of time, taking it for an extended period of time if you have a history of blood clots or embolisms. So this is just the pathophysiology and understanding the differences between the clots.
Now, this is a very, very fun diagram. So this basically explains everything that's happening Okay, so like I said, I'm not going to go into too much detail over here, but I want you just to pay attention to a few things. The menstrual cycle is divided into 3 phases, okay? You have the follicular phase, ovulation, and the luteal phase, which is also referred to as secretory phase, okay? So if you look down here, this is what we call the uterine cycle. And up here, this is what we call the ovarian cycle. Okay, so basically what this means is in the ovarian cycle, this is what's happening in the ovaries, okay? Versus in the uterine cycle, this is what's happening in the uterus. So day number 1 is referred to as menstruating, okay? So this is day 1. This is where we're starting. Now, in day 1, look at what's happening. For approximately 5 to 7 days, women have their menses. That's when the endometrial lining sheds, okay? That lining sheds and it comes out. We see that as blood. That's what your menses is, okay? So in this portion, you're also in the follicular phase where follicles are now developing within your ovaries, okay? Once menses ends, you're in the proliferative phase. And see, the proliferative phase is still part of the follicular phase. So over here, your follicles are still developing and your endometrial lining is proliferating as well, okay? Now, ovulation is key. This is where ovulation happened, and it's at day 14. Day 14 is when an egg is released from the ovaries, okay? And after this, the ovarian cycle goes into something called the luteal phase. The reason we call this the luteal phase is because over here, see this area where that egg was released? When it ruptures, it becomes something known as the corpus luteum. Corpus luteum. And that's how I remember it. Corpus luteum, luteal phase, okay? Over here, now in the luteal phase, the corpus luteum is excreting progesterone. See this? This is progesterone. Progesterone peaks over here because the corpus luteum is the one that's responsible for secreting progesterone. And if you look at the uterine, it's still in the secretory phase where basically not only did the lining proliferate, now it's actively secreting more lining, so the uterus becomes thick so that it can have a fertilized egg that can successfully implant. Okay, now this is all I'm going to say at this slide because as we keep going, it'll make a little bit more sense.
So let's get right into the case. We have LE, who's a 36-year-old female who comes because she needs a new rescue inhaler. And what she tells you is, I've been having trouble breathing and my rescue inhaler hasn't been working. So for the past 2 months, she's been experiencing several episodes of shortness of breath, palpitations, dizziness, chest pain, diaphoresis. That's sweating, that's increased sweating. And these episodes have come on unexpectedly and would sometimes lead her to think that she was dying. So she feels that they're asthma exacerbations, but when she takes her salbutamol, it's had no effect. And she's often thinking and worrying about when another episode will come on, so she keeps using the salbutamol just in case, prophylactically, up to 10 times a day in the hopes of preventing this. And she also has a family history of CAD, so she's been worrying that maybe she has a cardiac condition, so she started using aspirin also prophylactically. She's also been calling in sick to work. She's avoiding going out with friends because she's worrying that she'll suddenly have one of these episodes in public and she doesn't know what to do about it. She actually recently went to her family doctor and he told her her asthma is under control. So you can see the findings that I've listed, objective findings. She has her social history also here, past medical history, and her medications, all listed here. So take a look, and we're gonna get right into the questions. Number 1, what is the likely diagnosis for LE? I'm just gonna open up the live Q&A. So what is the likely diagnosis for LE? Is it an asthma exacerbation, agoraphobia, acute coronary syndrome, or a panic disorder? So A, B, C, D, which one do you think is a likely diagnosis? Okay, we're getting the votes fast and furious, and they're all for D, panic disorder. I would agree. That's what we have. Based on the information I provided, it's likely panic disorder that she is experiencing. Number 2, what are the potential drug causes of this condition? So from the drugs that she's taking, what could potentially be causing this? A, Advil, cold and sinus, B, salbutamol, C, caffeine, or D, all of the above. Okay, so now it's open again. You can vote if you want online. So A, B, C, or D for number 2. Which are the potential drug causes of this condition? Okay, we're all for D. I agree, all of the above. So all these could be contributing to those feelings of the palpitation and feeling that increased anxiety, certainly. Advil, cold and sinus. I don't usually use brand names, but it's something that we should be aware of, because somebody might come and say, I'm just taking some Advil. But if you dig a bit deeper, they're actually taking a cold and sinus prep, which is an Advil preparation, ibuprofen preparation with pseudoephedrine. So this contains pseudoephedrine. Certainly that can contribute to the symptoms as well. Okay, next question. Which therapy would be best for LE at this point? Duloxetine, fluvoxamine, buspirone, or propranolol? So again, we have, if you just refer back to the slides, we can see which ones are first line, second line. I might do a so there's just a quick question that I'll address now. If ibuprofen can cause anxiety on its own, so that is potentially it might have some association as well on its own. So yes, but I want specifically for this patient, she's been taking Advil, cold and sinus because of allergies, and so that's something that we should be aware of, that could be contributing because of the pseudoephedrine. So we have everybody saying B, and that is correct. So this is one of the drugs that is listed as first line for a panic disorder. So that's why the answer is fluvoxamine. And number 4, what else should you educate her on? So aspirin use, alcohol use, fluticasone use, or none of the above? Anything else you should educate LE on? Okay, we've got everything's coming up now. This is interesting. But looks like A is taking off. And I'm going to agree with that. So aspirin use. So if you recall in the case, I'm just going to go back so you can look at it. Okay, so she's been taking aspirin prophylactically. So that means just sort of preventatively on her own, because she has a family history of CAD. And so you can see aspirin, PRN pain, and she has been using it more recently. And this isn't your cardiology lecture, and I would refer you to your cardiology lecture about this, but really when we aspirin is not indicated for her in any way at this point, and except if she's using it for pain, it's one thing, but it's not indicated from a prophylactic cardiovascular perspective view. So she should not be getting that, and you should be educating her on that to let her know, this isn't appropriate to be using aspirin in this case.
So I know this is maybe kind of confusing, and that's why I'm going to draw you guys a diagram, because some of you may be visual learners, just to have you understand this a little better. So I'm going to switch the view now, and if you guys want to take out a piece of paper, a blank piece of paper, so that we can go through this together. I'm just going to change the color of the ink. And excuse my poor drawing skills, but I'm just going to draw, a head of a person very badly, but please bear with me. And then we have the brain here, very roughly. You know, we're not artists, so we're just going to use this as a simplified way to look at what really actually goes on. Okay, so as we get started here, we have our brain over here that I drew, and this right here, the structure right here, is your brain stem. And inside the brain stem, this hashed out area here is the medulla oblongata. So this is really important to at least situate yourself in our diagram right here. I'm just going to use an eraser and take out this now because we're going to go into more detail here. And you know what? I'm going to turn on the Q&A just in case you guys have any questions as I'm going through this so I can be of more assistance. Okay, so let's get started here. There are a couple key areas. So remember how we talked about the emetic center or the vomiting center? So that is right here in the medulla oblongata. And so I'm just going to expand that over here as our first key area to think about. So this is your emetic center, okay? And this is really important because anything that stimulates the emetic center causes your vomiting reflex. So the actual act of emesis, okay? So on the emetic center, we have receptors. And the most important receptor here is the muscarinic receptor. And this is what triggers that reflex. So you have triggering of this receptor that causes the vomiting reflex. Okay, everybody got that? Now we're going to move to the next one. So the next one is the CTZ. So that's the chemoreceptor trigger zone. So that one is somewhere over here, also in the medulla oblongata. And we're just going to bring this over, and we're going to have this here. So we have our CTZ. Really important to remember. Don't confuse it as a chemotherapy trigger zone, even though you can remember it that way because most chemotherapy triggers it. Think of it as the CTZ. Very important concept here. And there are two receptors that are very important in this area. Oops, I made this uglier than it should be. Let me just correct that here. Okay, so the two receptors that we have is we have this one that I just redrew. So this is your dopamine 2 receptor. And note that these receptors are really important because this is what determines the most optimal treatment. So we have the dopamine 2 receptor and we have the serotonin receptor. So this is the 5-HT receptor. So in the CTZ, we have the dopamine and serotonin, and that's why you typically use serotonin and a receptor antagonist like ondansetron to treat chemotherapy-related nausea, vomiting. Got that? So from the CTZ, there's also another trigger that triggers this entire process to begin with. For example, how is the chemotherapy going to actually trigger this reflex? Well, there in the stomach, here we go. I'm going to try and draw a stomach here. It's probably not totally anatomically correct, but let's say that this is the stomach. And so we have the stomach here, and inside the lining, we have these cells. And they're called enterochromaffin cells. And what they do is that when they are stimulated by something like chemotherapy, they release serotonin. And so then you have this serotonin 5-HT, that activates serotonin receptors over here. Oops. Over here. And then that goes to activate the medic center for the vomiting reflex. Okay, so this is not just always only stimulated by chemotherapy. You can have NSAIDs, which we'll talk all about this in the following slides to come, but you have antibiotics, you have NSAIDs, so anything that kind of irritates your stomach area could cause this to happen. So this we call kind of like when we look at the GI causes, okay? And then we have the vestibular causes. So when we talk about vestibular, I'm going to make it purple. So imagine we have a ear here. Really, hopefully you guys can kind of see what I'm drawing here. So this is a ear. So we have our vestibular. There's something called the vestibular nuclei. And so that's in the vestibular system. So that's your inner ear canal, the labyrinth, all of that, complicated anatomy structures that won't go into detail. But essentially, this is the most important thing you need to know, the vestibular nuclei. And here, again, we have two receptors. So here we have the histamine 1 receptor. And this is really key because if we have any sort of vestibular issues, motion-related nausea, vomiting, it's very helpful to use an antihistamine to treat that because because we can block this receptor, and that's why typically you have Gravol or Benadryl that's used. And then we have again the muscarinic receptor as well. So for this, any sort of acetylcholine would stimulate it. So you want drugs with anticholinergic effects that's going to help you with the vestibular system. So that is another important, I guess, system that is triggered. So I don't know if you guys remember from when I was just talking about that slide, but there's one more. And guess which one it is? It's the blood and guts one. So that is when you have effects or stimuli on your higher brain, or you can call this cerebral cortex. Okay? So this is when you have any sort of pain. Pain typically causes a lot of nausea, vomiting. We have sight or smell. Or sometimes emotions. Those are all of the stimuli that could possibly cause you to be stimulated that way and cause that stimuli to the emetic center in order to cause the vomiting reflex. So essentially, I'm looking at my diagram. We've hit all the ones that we wanted to talk about here. So if you have a good understanding of this system, you should be able, it would help you figure out which medications to actually use. So I'm going to give you guys a couple seconds to jot this down, take a picture, whatever you need to do. And then we'll go to the next view here. Perfect. Okay, so I'm just going to star this one, bring it up here. So Shahina asked, do anticholinergics help block muscarinic receptors on the emetic center as well as the vestibular system? So yes, so when we have anticholinergic drugs, they block activity of the receptors in all of the centers. So basically, when we talked, as you can see here, all of these different sensory centers also feed back into the emetic center as well. And so at the end, that's why we have that eventual gathering at the emetic center for the reflex. But ultimately, any drug that that is absorbed systemically is going to hit all the different receptors.
Okay, so say we do have a infectious disease. Say we've got somebody who comes in and they're looking fairly unwell. They've got a localizing symptom of, cough and trouble breathing, so dyspnea. We think they've got a pneumonia. So how do we actually start selecting antimicrobials? So we need to think about the type of infectious disease, number one. So that defines how we actually go about choosing an antibiotic. Because I can't just say you've got sepsis. That doesn't tell me anything. That could be sepsis from urine, it could be sepsis from an infected foot wound, it could be sepsis from pneumonia. So I need to know a diagnosis before I can start making treatment decisions about appropriate antibiotics for that patient. So give me a diagnosis, even if you're not sure. Tell me where you think this is coming from. And that leads directly to the likely microbes. So microbes have a tropism, meaning they have a specific area that they like to live. And I'm not trying to anthropomorphize microbiology here, but there are certain microbes that live in your respiratory tract, and there are certain microbes that live in your GI tract. And those are very dissimilar microbes. So if you see somebody who you just culture everybody, in your respiratory tract, you'll find things like some streptococci, you'll find some strep pneumoniae potentially, you'll find other sort of weird and wonderful oroflora that kind of make their way down. But you're not going to find enterococcus, you're not going to find fungi. It's very rare for that to occur, and that's true of the GI tract as well. You're not going to find a lot of Staph aureus and viridans group strep in your lower GI tract. So they've got different places that bacteria reside. And as a result, we actually have to think about which bacteria are most likely in that state that we think is the infectious process, and then how do we cover those bacteria with a selected antimicrobial. You think about it, this is no different from being a carpenter and just knowing which tool you're using for the job. You need to know what your job is, you need to know what the specifics of the job are, then you can select the right tool for the job. Not a lot of difference here. So we talked about the likely organism. Now it's the susceptibility. So organisms can either be sensitive or resistant, or they can have acquired or adaptive resistance that is occurring as a result of selection pressure. And so we determine, non-susceptible is actually a better term to define things that are inherently or intrinsically not going to respond to particular antibiotic therapy. Enterococcus is a great example. So enterococci are intrinsically non-susceptible to cephalosporins. It's just the way it is. There's no ifs, ands, or buts. They're not going to be affected by cephalosporin antibiotics. But when you see somebody who's got a recent trip to the Indian subcontinent and they've been hospitalized in India and they come back into your hospital, there's a high degree of likelihood that that person is going to have a acquired resistance gene for a gram-negative bacteria that they've been harboring in their gut, and that may actually lead to infectious disease. So if you've heard the term superbugs, that generally is termed by these acquired resistance mechanisms that you can pick up either in a hospital or traveling that are resistant to common antibiotics because of the exchange of plasmid-mediated information between one bacteria, one organism, and the other. So this is the idea of susceptibility. We'll talk about the antibiogram and trying to judge that, but more important than all of that is the patient-specific factors. So what's their prior microbiology? What's their current status? What's their exposure to organisms or to antibiotics been? Number 4, antimicrobial penetration. Does the drug get to the site of infection? And this is honestly, like if I were writing questions for this exam, I would focus on this one almost entirely because it's cherry picking. It's like this patient comes into you, they're a 72-year-old female who's got signs and symptoms consistent with pyelonephritis. Which of the following are appropriate therapy? And if you've got nitrofurantoin, fosfomycin, and, say oral, I'm blanking here, oral neomycin, you know right away that those 3 choices are incorrect. You can't get those drugs at sufficient concentration to the site of infection, which in this case would be the kidney. They're just not going to get there. So the site of an infection mediating or assessed by the penetration of the antibiotic you're selecting is really an important concept to grasp, because if you don't have this, then it doesn't matter what your drug choice is. It's just not going to get there. It's not going to kill the actual bug. Believe it or not, we are all probably taught this in school. I'm not sure it actually matters in most infectious diseases, but I'll say that the times where it does are those more severe infectious disease syndromes. So infective endocarditis, meningitis, things like that. But overall, the idea is that bactericidal activity will cause the bacteria on their own to be killed rapidly in the absence of an immune system or working immune system, whereas bacteriostatic will just halt the protein synthesis or other types of replicative processes within bacteria, and that will reduce the chance or make them less able to divide, but doesn't necessarily kill the live bacteria. So you still need to have a functioning immune system to kill them. And again, this is probably the least important. It's down the list of things that are clinically relevant, but it's something that's classically associated with infectious diseases, so we wanted to mention it. And the idea is PO versus IV administration. So in your career, you're going to see some big changes here. So right now, severe infections like meningitis, well, let's leave meningitis off the table. Let's go endocarditis. So endocarditis was always thought to require IV therapy, intravenous therapy. And this year, we've got a recent trial that shows that actually, after a couple of weeks of IV therapy, you can get by with oral therapy just fine. And so we're kind of blurring the lines between acceptable and not acceptable for oral to IV or IV to oral. But either way, understanding that there is a saturation, there's the lack of ability of your body to absorb certain antibiotics. There's also a max tolerable dose for a lot of antibiotics. So if you have a patient who isn't able to eat, if you've got a patient who's got really low blood pressure or bad heart failure, if you've got a site of infection that is really hard to get to, so CNS, for instance, you're going to need high levels of antibiotics in your bloodstream that are not going to be easily achieved orally. And that's why we think about the IV versus PO question. It's disease state dependent, and it's also patient specific. So we talked about antibiograms, or we mentioned them on the last slide. But the idea here is that an antibiogram is going to be a relative understanding. This is quite old, but the same process has changed. It's not changed, rather. What you'll see is that E. coli and all of your gram negatives here are listed out in terms of the relative number of isolates given to the microbiology lab. And then what you'll see is in the top, the different antibiotics, in this case listed alphabetically. It's done a bit different based on where you're seeing. And what these numbers correspond to is the percentage sensitivity. And I think this is it's a great slide, because if I were to see E. coli that had a 95% chance of being amoxiclav sensitive, I would jump up and down and just run. And that would be a fantastic outcome. But in, 13 years later, we've got rates of amoxiclav sensitivity in the, say, 60% range. That's not good. So that's the amount that's happened in the past 13 years. Not a lot of time to go. But as you see, these are the percentage susceptible for all of these different combinations of bug and drug. And so you'll see over time that you see a longitudinal shift and change in sensitivity patterns based on your patient population and your antibiotic usage pattern. They may give you one of these to interpret when you're having the exam. I don't know, I'm not sure. But I think it's really important to understand how to assess them. And really what you're looking for is an antibiotic that is going to get to the site of activity, that has a appreciably low risk for side effects, that is going to cover the bacteria, and looking at an antibiogram, cover it in a way that's likely to be effective. So that's why we look at these. And most recent guidelines would say that like a stratified antibiogram based on the sort of the location of the patient, where they're coming from, ER, ICU, along with the type of isolate that they're getting, so urine, respiratory, blood, does make a difference in your interpretation of how to apply this to a patient. So overall, this is a good example, but you need a little bit more detail before you can use it for a patient.
Okay, so the big focus today's talk is really on opioid use disorder. The first class I'm going to talk about is buprenorphine naloxone, better known as Suboxone. We can get buprenorphine alone in the market, but that's through special access through Health Canada. It's not available in the pharmacies regularly, but you can order it alone through a special access program. But probably the most you'll see in practice, Suboxone. So buprenorphine is a partial opioid agonist with kappa antagonists. Very unique pharmacology. So it's partial, meaning it binds the opioid receptor, binds very strongly, but doesn't create that full dose response that you would expect with a few full mu agonists. You get a partial half response. Naloxone is an opioid antagonist that is combined with Suboxone. It is given in a sublingual tablet in a disposable cup or vial because it can disintegrate if you handle it with a lot of heat or moisture. You need to see it partially dissolved. Sometimes it takes 5 minutes. Some other tablets I've heard anecdotally, some pharmacists says it takes about 10 minutes to dissolve, but you do need to see that it's been dissolved before you can let the patient go. So that's like daily observed dosing, right? Adverse effects, the most common one is headaches on initiation, decreased libido. With any opioids, you have a decreased risk and you have a decrease in sex drive, constipation, sweating, vomiting. Very similar side effects that you would expect to see in an opioid. Drug interactions, both pharmacokinetic and pharmacodynamic. Again, no surprise, similar to what we discussed in the previous talk. Buprenorphine is considered first line for opioid use disorder because of its safety profile and efficacy. It can be dosed between 2 to 24 milligrams per day, given once daily, or alternate day dosing. So because of its long mechanism of action, because of its long half-life, in some situations we do dose it Q2 days for opioid use disorder. But more often than not, you see it once daily dosing. 24 is a maximum recommended dose on the product monograph. Some clinical pearls to think about Suboxone. So it's got a ceiling effect as buprenorphine, making it safer than methadone. So overall, less risk of overdose, right? It has a ceiling effect. It's a partial agonist. It doesn't really hit those high levels that we would expect in a full mu agonist that increase that risk of overdose and side effects. It has a lower potential for misuse, not none, but lower. It has a lower withdrawal profile. So if you are tapering off of buprenorphine, tends to have less withdrawal symptoms. It tends to be less sedating and better tolerated methadone. It's got a slower onset of opioid tolerance. That's some theories, and that might be due to the the kappa antagonist properties. And also it might have, theoretically, less risk of hyperalgesia, which is one of those opioid complications we talked about. So for that reason, it's safer, it tends to be better tolerated, and it has some unique properties that makes it really first line, and it's shown to be very effective. Now, naloxone is funny. People ask, why do we have naloxone? That's an opioid antagonist. Wouldn't it make an opposite effect? Not so, because naloxone is added in. It doesn't cause withdrawal because it's got very poor oral bioavailability. Okay, so it's really added in to deter crushing, right? So if you take it normally, appropriately, orally, it doesn't bind or block the binding of opioids, right? It's fine. It just prevents them from misusing. So once someone misuses Suboxone, they start to crush it and inject it, that allows the naloxone to kick in, and that it causes withdrawal from the Suboxone, withdrawal from the buprenorphine. So again, it's there mainly to deter crushing and abuse of the medication. But if used appropriately, it's not going to affect the absorption of the opioid.
So now we're going to go and get into the treatment of hyperkalemia, okay? So before we move forward, I'm going to show you here that we want to treat the electrolyte imbalances. So why have I been talking about treating hyperkalemia all lecture? So the reason behind this is because in hyperkalemia itself, what happens is this is the most dangerous electrolyte imbalance. When it is higher, it actually goes and causes arrhythmias and for your heart to beat at a different pace, and this can cause mortality, which is definitely more abrupt and more noticeable than high phosphorus, for example. Because of this danger associated with hyperkalemia, we really want to make sure we address this in a super timely manner. So we have a bunch of medications we use, often in combination, through an algorithm to kind of help you treat the hyperkalemia. So we'll go through it in a stepwise order, and hopefully it'll make some sense by the end of it. The first thing, the very first medication you always do. So hyperkalemia is when the potassium is greater than 5. And we really start to worry when it's greater than around 5.5 to 6. Around 5.5 to 6, and when it's above that, you might start to see some symptoms. And then above 6, closer to 7, between 6 and 7 is the danger zone. So if it's above this, we're really starting to get concerned, because this is where we can start to see some of those arrhythmias really, really kick in. So the first thing you always do with hyperkalemia is this. You need to start calcium gluconate, and it must be IV. Okay? The reason this is always the first step, so this is number 1. We'll put a number 1 here. The reason why this is the first step is here. It actually stabilizes that membrane and increases that threshold to prevent the ECG changes and to keep the heart from doing an arrhythmia. So it increases the amount that it takes to produce that arrhythmia. So essentially it buys us some time. Has a pretty fast onset. And of course the risk is hypercalcemia because we're pumping in more calcium, but this is not an acute concern. So the first thing you do when you have a high elevated, especially symptomatic hyperkalemia, is you use that calcium gluconate right away. So after we do that, we still have all of this free potassium floating around our body. We still have a very high concentration of potassium into our blood. So we have to get rid of this out of the blood really, really fast. We need to get rid of this potassium really quick. So the first thing we do is we're actually going to go and hide it inside the cells. So it's hard to get rid of potassium at a very fast rate. It's much faster to hide it into the cells temporarily. So the two medications we do for that, insulin and salbutamol, okay? So these are both number 2. So one of these two drugs, or both, are going to be used to push that potassium right into the cells. So we want to hide it, because the longer it stays in that blood, the higher chance it can cause an arrhythmia on that heart. So what happens is we shift it into the cells, we temporarily lower the blood levels, knowing that it's eventually going to restore. So this is an acute thing. So this is to address it very quickly, because you can see here, the onsets of both these medications are actually quite quick. It is important to note though, with insulin, if you're using it for the purpose of hyperkalemia, you do need to use it with dextrose, okay? If you don't use insulin with dextrose, you can cause hypoglycemia, because now we're lowering the blood sugars actively. So, step 1, we go and we IV calcium. IV calcium gluconate right away to help stabilize that membrane, prevent those ECG changes. Step 2, we hide those into the cells right away. Hide the extra potassium into those cells short term. Insulin or salbutamol. The calcium bicarb can also go and shift into the cells, but it's only if it's acidotic, and it's definitely less common. You'll see these two used a lot more. The third step is going to be to get rid of it, okay? So these are the 3 drugs that help to get rid of it, and the one I want you to really know is Lasix, okay? Dialysis will always work in every situation, and this is like a desperate measure, but there's a lot of prep work that's involved in dialysis. So if it's very high, we can't get the other ones working, or there's reasons we can't, we resort to dialysis. But the one that we always do afterwards, unless there's a contraindication, is IV furosemide, okay? So using our loop diuretics gets rid of that potassium very, very fast. So the 3 steps. 1, calcium IV. Why? Stabilize the membrane and prevent those ECG changes, okay? Step 2, hide that potassium right in the cells. The 2 drugs we use that, insulin and salbutamol. And then the last step is to get rid of that potassium. And the fastest way and the most effective way is going to be with IV furosemide. So as we start to get rid of it, then the potassium will eventually leave our cells back into the bloodstream and start to stabilize over time, which is why we do it this way, because it's the best way to address all the acute situations. Okay? So, with me one more time. 1, calcium. 2, hide it. Insulin and salbutamol. 3, get rid of it. IV.
Constipation.
This treatment algorithm, if you leave this lecture with anything at all, leave with this. This one is very, very important, so I'm going to take some time to go over this algorithm. Then all the other slides are basically going to be reiterating what I've just told you over here. So now, let's go over this algorithm very carefully. So, patient is presenting with vasomotor symptoms. The first and most important thing you need to understand is the patient perimenopausal or are they menopausal? So, When was the date of their last menses? If it was less than a year ago, they're perimenopausal. If it was over a year ago, they're menopausal. Now, look at the symptoms. Are they only having mild symptoms? And how do you gauge that? You ask the patient, so explain to me what's happening. So initially, like again, I keep going to the example of my mother because that's the one that I've dealt with for years and I know. So my mother initially presented with just simple mild symptoms, and I would ask her, I'm like, what is happening? She's like, well, at night sometimes I get hot, but I can easily manage, you know. I usually take off my blanket, I turn the fan on, or I turn up the air conditioning and I'm okay. So I'm like, Mom, is it bothering you? Is it waking you up from your sleep? Are you actively feel that you need something to help you manage it? She says no. So that in my mind is a mild symptom. So for mild symptoms, you always recommend non-drug measures. So all the measures that I noted, you recommend non-drug, you don't go to drugs just yet, okay? Now, if the patient is having moderate to severe symptoms, these can be they're waking up from their sleep, they're actively sweating throughout the day and at night, their skin is itchy, they're just not feeling, they're irritated, like they're just not feeling themselves, they have breast tenderness, etc. It's just a mess. Those are moderate to severe symptoms. Now, the second question that you need to ask, does this patient want contraception? Okay. They might be perimenopausal, meaning their ovulation is irregular, but it doesn't mean that they're not ovulating at all. They can still be ovulating, and if a patient does not want to get pregnant, it's important that you give them contraception as well. That's why this question is very, very important. People assume that, especially with women, if they're over the age of 40, they can't get pregnant. That's not true. They're still ovulating. It's a little irregular, but they're still ovulating, so the risk of pregnancy is still there. So that's why this question is very important. So, is contraception required? Yes, it is. We're going to look at the no when we go through this side, when we go through the right-hand side, but right now, contraception is required. Now, do they have any contraindications to estrogen? Okay. The lack of estrogen, the lack of systemic estrogen is what causes the vasomotor symptoms. Okay, that's very important to understand. Since you don't have systemic estradiol in your body, so this is also answering the question that's posted, difference between estrone and estradiol. Before menopause, estradiol is the one that's being secreted by the ovaries, and it's a very potent form of estrogen. After menopause, your peripheral cells, like your fat cells, they're still producing estrogen, but it's estrone. It's a very, very low potency estrogen. So the body does not have enough to overcome the symptoms that it's experiencing due to the lack of estradiol. Okay, so now, does the patient have any contraindications to estrogen? They don't have any contraindications. So contraindications, like I said, history of DVT, are they a smoker, are they do they have breast cancer, things like that. They have no contraindications to estrogen. So now, what you will consider is a low dose hormonal contraception. Okay? Low dose hormonal contraception that you can take, which is you can take a combined oral contraceptive pill, etc. It will give you the estrogen that you need, the progesterone that you need, that will basically give you the contraceptive protection as well as replete some of the estrogen from your body. You can also give them the levonorgestrel IUD plus estrogen. Remember how I said estrogen is what's important to get rid of the vasomotor symptoms. So the levonorgestrel IUD is purely there for the contraceptive purposes, and the estrogen is purely there to decrease the vasomotor symptoms. Okay? Third option that you can give them hormonal therapy. Now, when I say hormonal therapy, it's different from the contraceptive hormonal therapy. Hormonal therapy for menopause contains much lower doses. It contains much, much lower doses of your hormones as compared to contraception. In the contraceptive hormonal therapy, you have high doses of both estrogen and progesterone that prevents unwanted pregnancy. In menopause, you just want to give the body enough of the hormones so that these symptoms are alleviated. So that's why hormonal therapy for menopause you can recommend, but because they require contraception, you have to give them a barrier contraceptive with it. Because the hormonal therapy, the low dose hormonal therapy for menopause is not going to be sufficient contraception. Okay, so I hope that makes sense. So barrier contraception and the levonorgestrel IUD is specifically there just for that. Okay.
A common source of confusion, the definition of a zero order versus a first order process. So a zero order process, also known as nonlinear, which is confusing because the shape is actually linear. And then first order, which is actually linear. But remember, when we refer to a nonlinear zero order process, this has to do with our PD curve, whereas our linear process refers to, so it's dose over CP, and this is dose over CP. So that's where the terms nonlinear and linear come from. Zero order comes from the fact that rate of excretion is concentration independent, meaning it's K times C raised to the zero order, the zeroth order, which we know is equal to K times 1, or just equal to K. Rate of concentration for first order, we know that the rate of excretion is concentration dependent. So it's K times C raised to the power of 1, which is obviously equal to K times C, our concentration, our CP. Right. And that is the difference between zero order and first order. Okay, so a reminder then that we do have a series of questions provided for you in this lecture set, and the problems that we did not go through and solve today, those are for you to take home and study. There's some throughout and there's some at the end as well, and we're going to go through and go through those examples in detail during our calculations